Thanks very, very much. Well, good afternoon, everyone. Welcome to this special presentation today on best practices in health plan and home care partnering for emergency preparedness. I'm really excited to say I think that this is really a very unique and a first-time event of having really this important joint focus on health plans and providers and the way they work together in really among the most vulnerable circumstances in the healthcare system, such as when there is a disaster at hand. Of course, health plans and providers have to work together every day through the complexities of navigating care, coordinating care, and really all of those pieces. But this is especially so in the vulnerable circumstances of disaster. And as I say, I think this is the first time there's been such a presentation, certainly that I'm aware of, and I've been working in the emergency preparedness field for the better part of 20 years in my role here at HCA. But I'm Al Cardillo. I'm the president of the Home Care Association of New York State and of HCA Education and Research, which is our 501c3 charitable affiliate. And we're here today with our partner, CenterLight PACE, to bring you this important presentation today. And you can see, you did see his face before, but Peter Chernick, who is our executive vice president, is also joined us today. I'm going to not be announcing the rest of our team here momentarily, but I will give you a little bit of an overview of this session. We will be acknowledging our source of support, really critical support for today's program, giving you a little bit of a basic understanding of the structure of home and community-based services as it's applied to emergency preparedness. So in our audience today, which includes over 100 organizations, over 100 participants, we have organizations from all circles, from emergency management to providers across the continuum, could be hospitals, long-term care facilities, really organizations across the continuum, EMS, that are part of this. And it's really essential, and I think a great opportunity that is part of talking about the emergency preparedness aspects of health plans and providers to also include some very fundamental pieces of information about how plans and providers, work together ordinarily in the system. I can say, again, as a person who participates at all levels in emergency preparedness, it's really not well understood. Very often on the part of whether it's a utility company, or a regional county manager, whomever it is, they're not living in the weeds of the everyday environment of managing Medicare and Medicaid and commercial patients in the long-term care system. So this is a great opportunity to also give that kind of foundational background, which is important in their exercising their collaborative relationship with home care and plans overall in emergency management. So this will accord us that great opportunity today. We'll talk about, what are the emergency preparedness requirements for plans and providers? Why is this partnering in EP so critical? And the ability to execute, just why is that so important in the system? Then we are delighted to bring you best practices. What are some of the things that work most effectively for plans and providers as they have to work together in this? And that will actually go to some specific scenarios, which our partners at CenterLight will be delving into to say, well, here's in scenario A, this is how we effectively managed. These are the best practices that we could recommend from that. And one of the things that we want to do in this is we want that discussion to be interactive. So, we'll talk to you about what our experiences have been, and the kinds of things that we think are effective in practice. But we also want to open the channels to hear from you. So there'll be an opportunity to do that, and of course we'll encourage you to do that. And then we really want to conclude with a discussion of challenges and goals. Like, one of the things that really differentiates care in the community from care when someone's in a facility is that in the community, it's happening across a broad geography. And so potentially every city street, every house, every part of the region is its own unique emergency, because whether it's a tree down, whether it's power lines down, whether it's no access to the pharmacy, regardless, it is a different manifestation of the emergency, and that is one of many things that really create a much different kind of challenge for the home and community based system, as let's say, versus say would occur in a hospital or in another consolidated setting. So we want to address some of those, and again, we will similarly invite you. Just before we get started into the next portion, just a little bit of housekeeping. Number one, the chat will be open throughout. So please put your questions, your comments in the chat. We will address them as we can. If you, we will try, however, to hold and coordinate questions to the far end of the presentation, and that's really so that we can make sure that we've covered the content adequately, and there may be questions that are answered subsequently in the content. So to avoid that redundancy, we'll do that. I think with that. Oh, and when we come to the interactive time, if there's an opportunity there appropriate to unmute, we'll invite you to unmute and sort of jump in with our conversation. So again, welcome to our program today. I will acknowledge as we go forward that this is being provided to you with support from a grant from the U.S. Department of Health and Human Services Administration for Strategic Preparedness and Response, often known as ASPR. And this is a grant that is administered by the New York City Department of Health and Mental Hygiene, the Office of Emergency Preparedness and Response. I can't thank the Department of Health in New York City enough for their support of these efforts, and really all the work that we do as an association for emergency preparedness, and ultimately that's a resource to all of you wherever you are in the healthcare continuum, whether you're a plan, a provider, an emergency manager. We are all the beneficiaries of this very hard work that New York City does. And a special shout out to our senior program manager, our project officer, Fidel Monroe, who is a nurse with great experience in home and community care. And Fidel, thanks for all that you do in support of the program and the work that we do.
You're welcome.
Oh, there you are, Fidel. I didn't see you on, and thanks for coming on. Any comment that you'd like to make up front?
Like you stated, Al, good afternoon to everyone. Welcome. I'm the Senior Program Manager, and I'm also the liaison to home care and the hospice and palliative care from the New York City Health Department. This is an innovative session, and I hope that you can take from this and enhance your comprehensive emergency plans. There's something here that each one of us can learn today. So sit back, enjoy, ask questions, put them in the chat, reach out afterward to the association members and be heard. That's what's important. Thank you.
Thank you so much, Fidel.
You're
At the end, we will certainly be sharing the slides with everybody. When you gavel out at the conclusion, just if you could please participate in the evaluation of the session, send us your feedback, let us know how we're doing, and also look for information about related sessions that we've held. We've been working for the past 6 months with Fidel. Peter's been leading this charge along with colleagues at IPRO in infectious disease, effective infectious disease management, really especially focusing on new and emerging diseases within the system, novel viruses, and so on. Those sessions we've recorded a sequence of 5 sessions. We've also done in-person sessions at which our colleagues at CenterLight were really a great participant in trying to guide in the tabletop. We'll be doing a lot more of that as we go forward. And again, we hope if you like and benefit from today's participation, that you'll follow up with us, and be really a robust part of the planning and implementation process. Okay, I already introduced myself. Amina and Marlene, would you like to introduce yourselves, and then we'll move on to an organizational introduction?
Absolutely. Thank you, Al. And good afternoon, everyone. My name is Amina Tabakovic. I'm the Senior Vice President of Operations and Shared Services at the CenterLight. Today I will be joining and presenting with my teammates. I would like to, first of all, introduce the team that is in my office. I have Nancy Bennett, Head of Facilities and Housing, Mr. Hector Nolasco, Head of Security, and I'm handing it over to Marlene and Hector Hernandez to introduce themselves.
Thank you, Amina. Good afternoon, everyone, and welcome to this important meeting. My name is Marlene Descolin. I am the VP of Clinical Services. Naturally, I'm an RN who has many years of experience in the home care community. And I'm glad to be here to share some experiences with you guys. Welcome.
Welcome, everyone. My name is Hector Hernandez. I'm the Vice President of Business Development and Intake Management. I think it's a great opportunity that we can share some ideas on how to better the experience that our participants and patients and members have in the community. And having a program like this and to share those ideas and take them back to where we are, I think is pivotal. So thank you so much, Al, for this. And thank you so much for the partnership.
Thank you. So just a little bit about the Home Care Association. The Home Care Association, we're a statewide association. Our mission is to promote the quality and accessibility of healthcare and support at home. We are a 501c6 nonprofit, and we also are a 501c3 charitable organization, HCA Education and Research, which is really the organizing entity for this grant and these education services that we're covering today. We're comprised of health systems, healthcare providers, health plans, freestanding agencies that are federally or state licensed to provide home and community-based services, along with allied organizations who really support these services in the community. We cover all geographic areas of the state, and I won't read all of the types, but you can see from the screen the kinds of provider and health plan and affiliate types that are part of our association. And I will yield to Amina to discuss CenterLight.
Thank you, Al. I'm very proud to say I've been with the PACE program for 20 years, but they were established in 1985. This is a not-for-profit managed long-term care organization. We're providing the services at home. So instead of participants being in the nursing home, that we're keeping them safe at home. We're operating with the mission of providing individualized care to enrich the lives, those who we serve, and help them live safely in their homes. We are one of the oldest, and I'm very, very proud. I think we are the largest. I think we're somewhere close of 6,700 members. One of the distinguished features of CenterLight Care Model is our team-based approach. We do have 11 PACE centers and one ACS. It's an alternate care setting where we are serving a New York metropolitan region. Our team of healthcare professionals work side by side to provide knowledgeable, attentive, and culturally sensitive care to our members. I just want to point something out. Most of the team members in CenterLight side are bilingual. Very proud to say that our ACS in Jamaica is specifically, it was made and built to assist with our Asian population, where we have special rooms where we're providing the prayer services. Very, very proud of that. We make the news a few times. Very excited for that. But each and every location in the city, we have a Grand Street that it's mostly Cantonese and Chinese speaking, then going to the other sites. But what makes us really, really special is that all our staff is bilingual. And if you guys have any interest in joining or referring someone to PACE organization, Mr. Hector Hernandez will help us out. Thank you.
Thank you so much. I certainly would underscore the comment you made about cultural and linguistic alignment with the population. I mean, you can imagine that in ordinary circumstances, how critical that is for the quality of care that is provided. But in emergencies, communications are just hugely impactful, and the ability to communicate and coordinate and organize, just so heavily relies, on that ability to be in sync. So again, awesome point to emphasize, Amina. Okay. So let me. I'm going to go. The way we're going to do this is that I'm going to run through some of the 300-foot pieces of information on this, and then as we go through, if there are then our further specific comments, then the CenterLight team will just weigh in. At the end of each slide, I'll pause for a moment. They may weigh in with a point of emphasis or another point to add, and then we'll go through. And then particularly when we are on the best practices component, we'll switch over, and the CenterLight team will take the lead in presenting the slides. But there's no exclusive to the commentary on any of the pieces, and that also goes for you in the audience. Please weigh in with any points you want to emphasize. Okay. So what are we structurally, in New York State in terms of home and community-based services? Well, there's over 1 million people that are served by this system, and it's really essential to understand that this structure, because the health plan provider structure is really the main model through which this million individuals, the preponderance of the million individuals are being served. You see the list on the slide before you, the kinds of providers that actually are the deliverers of the services directly, and then the various types of health plans that we have within the system. And today the health plan side of this is represented by the PACE. A majority, as I said, a majority of the patients are served in this kind of partnership. What happens is that recipients enroll in managed care. They enroll largely through what's called the independent assessor in New York, through Maximus. They're the conflict-free assessor, and they determine initial eligibility and then initial assessment for services. And with few exceptions, all individuals who are dual Medicaid and Medicare and age 21 and older are enrolled in the system, enrolled in this type of a system, an MLTC PACE type system, along with providers. PACE eligibility is from 55 and older. MLTC eligibility is 21 and up. If they don't meet the criteria for MLTC or PACE, the medical criteria for that, or if they're not dual Medicaid, Medicare eligible, they may receive services separately, such as through a local Department of Social Services or through a home community-based waiver program like the Nursing Home Transition Program or the Care at Home waivers for children. Of the population, of the Medicare population in New York, over 50% are enrolled in Medicare Advantage plans. So the entire system, whether it's Medicaid, where these requirements are in place, or Medicare, whether it's the option, again, the vast majority are accessing services through managed care. Okay, so in terms of the requirements, for home care providers, so this is home health, hospice, licensed home care services. There are both federal and state requirements that apply. So in the case of home health, it's right part of the federal conditions of participation. They require certified home health agencies to establish and maintain emergency preparedness programs that comply with these federal standards. For anyone who's part of our discussion that's not familiar with the conditions of participation, they're in the federal code that you see referenced on the slide, but all of the Medicaid, Medicare providers, are required under federal standards to meet these conditions of participation, and they're very extensive. And around 2017, the federal government developed a very, very high level section for emergency preparedness as a basic part of the conditions of participation. So if you want to participate in Medicaid or Medicare, you have to have these plans in place, and they've got to be robust. Similarly, that applies to hospice programs. The New York State, in its own regulations, New York State regulates licensed home care agencies. They're not directly federally regulated, but the state's guidance pretty much mirrors The same COPs that are in place for hospice and for home care, they mirror those for licensed agencies. So if you're not otherwise directly subject to the COPs, you're indirectly subject through the nature of the state's regulations. And this really provides for uniformity across the entire home and community-based structure of these standards. The state's model contracts for health plans also require them to have robust emergency preparedness plans. And so there you see here referenced on the slide the actual DAL, the administrative directive of the department for emergency preparedness, but it also requires providers and plans to have emergency preparedness provisions in their contracts consistent with DOH regulations. So the regulations themselves for plans the department has and the contract provisions, again, further mirror what is federally required, and they recognize and require this partnership to be in place. So one of the things in talking about best practices that's really important is it's one thing for it to be in place on paper, but what's really important is for it to be in place in reality, in the ebb and flow of what plans and providers should be doing together to prepare for, to begin the response for, and to fully execute that response to the emergency and the after effects, the after actions that need to take place. We conducted a tabletop session, which are, so there are these exercises that you're doing in situ. You have providers and plans, in the meetings. We conducted 2 of them in New York City in the month of May, and there were breakout tables, and folks went through simulated emergencies and talked about what their respective roles would be, and it's very interesting because there's a great deal of diversity in terms of the response that you hear, perhaps from plans or perhaps from providers, which is all in the right direction, all with the right intent. But what we see with our eyes and with our analysis is that there's a tremendous amount of room to be working to actually help refine those procedures and to really assist you with the kind of synchronization that's so important, so that once the emergency is already in play, that you already have the best practices in hand for how you're going to manage that together. Doctor's orders, care plan changes, evacuation of family members, alteration of services, like all of that kind of thing is best served when the plan is clearly understood and folks know exactly what they need to do. So while we saw evidence of, mutual recognition, we also saw evidence that there's a lot of room to work toward, improved practices, and that's what we want to support. And today is a really good step in that direction. Why is this so critical? Let's just talk about some of the steps and some of the real pivotal points that make this so fundamentally important. So services are authorized by the plans and they're delivered by the providers. So again, those two things just absolutely go together. And so that's not only important on a daily basis, but obviously in emergencies. And if we just look at what some of the challenges were in Superstorm Sandy, or in COVID, or in other disasters where things might not be clear on how they're going to be done, like, is there any regulatory flexibility? Do you need prior approval? Is there going to be, is there clarity on whether you'll be reimbursed if you needed to make changes and you didn't have the doc in plan, or you couldn't get your case manager? So again, that synchronicity is all really very important. Those communications are also really critical when you're trying to ensure continuity of care, because again, things may change drastically. If somebody depends on a family member every day from, let's say, 6 o'clock until 8 o'clock the next morning, and now that family member can't get there, well, what happens to the patient? how do you deal with the modification of the care plan? How do you deal with the authorization? And also just the ultimate disposition of the patient if you need to move them to another location to receive services, if they have to go to hospital. Again, so the communications and continuity are really so critical. And I've talked about many of these pieces as I've gone through the slides. So again, another essential part of this is even beyond that level of coordination is that you also have mutual responsibilities to stay informed about patient status, because the status itself may change from one day to the next in the emergency. Number one, because of the emergency, but also that status may change because of, a change brought about in the patient's condition during the emergency. If they've depended on medications and they can't get it, if they're dependent on certain food or a certain diet and they can't manage that, again, all those things become an issue. And the health department will be looking for, an indication of your roster. Do you know where your patients are? What are you doing with your level ones? Are you able to accommodate them? And of course, we've all seen the herd surveys, and those, are an imperative that we're required to file. So, I mean, ultimately, the whole bailiwick really depends on the coordination in patient care and follow-up. Before I go to the next slide, CenterLight team, anybody want to add anything to what I said on this slide?
Nothing to add. You covered it great.
Okay. Okay, so now let's just go to a little bit more on that, and then we'll pick up with the practices. So, in looking at the requirements and in meeting the requirements, the partnering really has to begin with the emergency planning process. In our slides, we have extensive, in the appendix, we have the details of what those requirements are. But to make the point, so I would ask the plans and ask the providers who are on the call, do you work together in the planning process? The health plan has its plan. You as an individual agency have your plan. Those plans also have to include, what is your plan for outreach to essential community partners? Again, EMS, utilities, county managers, all of those pieces. To what extent is your planning coordinated? To what extent are there gaps or differences? And do you know in advance what the MO is of your partners? So again, emergency preparedness really starts with that comprehensive emergency planning process. To the extent that that's not something that you do in depth or perhaps enough, that's also something that as an association, we're happy to support you on. So if we get feedback from the session of saying, hey, HCA, we could really use some joint sessions that focus on comprehensive emergency management planning and how we do it together. We are so happy to put that together for you and offer it, kind of on a going forward basis. We also have a lot of resources that cover sessions that we've run on those topics before that we can make available, but we're happy to work with you prospectively. So the other part of it is the planning process really needs to be supported and to be made real through participation in trainings and exercises and the fulfilling of the state and federal planning requirements. So there are requirements that you participate in exercises. One of the things that we have brought to our coalition partners in New York City, in regions around the state, and in the state health department is really an importance of including this relationship between the plans and the providers in emergency preparedness, planning, and in these exercises, because if you're not there practicing it, it's really hard to identify what the strengths are and where the gaps are. So when we did these tabletop exercises in the course of May, and we did them last year as well. One of the things that you can really help pinpoint is, where are the gaps? Where are the areas that need work and reinforcement? So that's really an important part of the process. And again, we're really pleased to be working with our city, state, and regional partners toward that end. But what's really important then is if we create those opportunities for you to be part of them. The other thing that's very important in that is that there are other partners who are parts of those exercises: the hospitals, the nursing homes, county managers, and there's no place and no time like now when you have the opportunity in these exercises to sort of connect, trade contact information, and just be basically familiar with who and what you are respectively to each other. There's no better place or time to be doing that. And very often it's the case that those other organizations have no idea who you are. You have no idea who they are, except maybe you have a contact list, but that's maybe 2 years old. So again, really, really important to be connecting with those sources, and by going through these exercises together, plans and providers, you're really maximizing the opportunity for successful continuity of care and patient protection in these emergencies. The other piece of it involves a training that you can do on your own, that you should do on your own and with staff. So there are resources that we actually advertise constantly in our newsletters. There's a training being offered on burns, a training offered on power outages, on cybersecurity. I mean, so these things are not only really critical for patient care, for compliance, and all that, and all that goes with it, but they're really critical, in helping your readiness for when there are such circumstances that need that kind of training and intervention. But aside from those special things that we're again constantly putting out to you through our alerts and our newsletters. But under FEMA, there's a whole system called ICS, Incident Management System, 100 through 10,000, levels. But again, and that is available to each of you as an organization, and the extent to which your individual staff, whether they're clinical or supportive, it really doesn't matter, that the staff understand kind of the common language and the common framework for emergency preparedness, which is really found in ICS. So ICS isn't necessarily coming with a health-tempered delivery. But it's basic emergency management planning and execution of response. So the extent to which you're all on the same page together with your partners, but also with community partners, is really important. So I've been in sessions before where I've asked a room full of provider and plan representatives, how many of you have taken ICS? And maybe one hand or two hands, three hands go up, and there are no other hands that have gone up. I've also been in rooms where someone's raised their hand and said, we have every person on our staff, and it doesn't matter what their role is, every person has to take basic ICS 100, and then you kind of go up the channel. So again, just putting that out to you in terms of the requirements, that's a really important element to take on. And again, we can help you with that, but you can go to the FEMA site. Information is right there. We also did a special webinar that was hosted by Barb Citarella earlier this year, where she focused on, or actually this was last year, that she focused on the latest in the resources for individual training. The other thing that's an important requirement is to ensure that you have the priority classifications on your rosters that are accurate and up to date. So you need to, those level 1, level 2, level 3, that really needs to be up to date, as well as the transportation assistance levels for patients. That's all has to match up. And I think many of you know the transportation assistance levels, which are called TALs, that those were updated, by the state, and that so your TALs coding, if you will, in your patient roster should reflect that. And plan again. This is where plans and providers like you. That's got to be synchronized so that both yourselves as the plan and the partners, who those patients are and what the plans are for addressing that. Further on the response side is patient safety, continuity of care for the patients, and then tracking and reporting of patient status. And we already talked about HERDS. So before we go on to the next slide, any further questions or any further comments or insights from our CenterLight team? Or does anybody want to put anything in the chat that you might want us to comment on or that you might want to comment on?
Well, this is Amina. I've been checking the chat. I haven't seen any questions, but the importance of upgrading and being on top of knowing the priority for the participant at what level they are, it's crucial. Also, just the cheat sheet, so that we're also used to having computers. We once a month print that out for each and every location that we cover, because in the case something happens, computers are not working, because we have our emergency preparedness boxes at each and every site. Once a month, we actually print it out for God forbid, if something happens, if we have no power, everything goes down. So I think that was an excellent point that you brought up, that's really, really crucial and to be updated on time. I just wanted to point that out.
Thank you so much, Amina. Yeah, and because it's so much is really riding on those updates, and it's interesting you mentioned that in our in-person tabletop training exercise, agencies had different takes, on their readiness with that. But as you describe it, that what you just described is really one of the most proactive things that you can do, that an entity can do to make sure that you're on top of those changes, and you've got the most recent and current information, before you. I think everybody on the call appreciates, or in the meeting appreciates that, level 1 patients, I mean, by definition, they can't really go without care. So you need to make sure that people who are level 1 are there, or if there's a need to transport that individual, to evacuate them, you need to know what asset that you need. If they need to be moved supine, you can't have them in a category that they're ambulatory and can get in a vehicle and just go.
I'd like to add one more thing to what
Please.
you stated earlier, Al, in terms of being ready prior to a disaster. One of the things we implemented here is because we have 11 sites that are PACE, and they are located in different areas, different regions, etc. So with that being said, we initiate contact with our local fire department, local police department, because in an emergency, having 11 sites, you have to be familiar with where your population live, because those are the partners. Not only they're going to help you with evacuation, but also if there should be power outage, you want to have your priority list available. And you want to call those partners. You don't want to call 911, because at that point, the line 911 is going to be overwhelmed. So you establish communication. You know who your leaders are at the local police department, at the local fire department, so that you can access them and get quicker and prompt response for those participants who needs that. But it has to be done prior to the disaster. Once the disasters pass, then at that point you are scrambling and you're not getting responses.
And if I may just add on to what Marlene said, MOUs, Memorandum of Understanding, it's extremely important that the team that is on the call updates those once a year, because we have actually either a school or facility. If something happens in our facility and we need to evacuate, those are very, very important that you keep up to date, that every year you check those, that you update those, that you get that signature. And to what Marlene said, it's the partnership that are very, very important. 911, everyone will call 911. But if you have that secret number, that it's direct line to someone, it's very, very important. Lessons learned.
Yes, and those are such great points, because we want to be effective partners in the process. So we need to accomplish, right, our patient care related goals and our continuity of operation goals efficiently and effectively. So for that reason, everything that you just heard is so important, but also we want to be good partners in the process. So we're always working to try to prevent the overburden in the ER, over dependency on that. We want to help with decompression on the hospital side. And if 911 is getting flooded because that's the default, that's not the direction anybody wants to or should go in. It's also obviously, not the least expensive default option either. In our system as we're all trying to control for things. So those are really, really excellent points. I want to just add because Amina brought up the idea of the mutual aid agreements. So we actually held a special session for best practices on developing mutual aid agreements between home and community-based providers. I mean, very often it's hospital to hospital, or it may be one partner to the other, but they're more vertically oriented. But we did a special session so that home and community-based partners really focused on the best practices for that. And so if you're interested in learning more about that, if you put your name, you express your interest in the chat, we'll make sure as a follow-up to send you that. And really, we can send you some of the other special ones that we've been doing. One other point I just want to make about the power. So you're on top of your game. Your practice puts you on top of your game proactively on power outage issues. I can tell you that when I've met on behalf of the Home Care Association with utility companies, very often their focus is on a very narrow set of people that are in their homes. They may be power dependent because of ventilator or other needs of that nature, but we know that most of our people are really dependent on power. Your level 1 patients, they're probably all dependent on power. And so I think it's so critical that as entities, you are separately on top of that, because as the utility company is trying to do their own triage and figure out who they respond to first, they're likely to have a much narrower understanding of who the vulnerable patients are in the community than what your realities really are. So I think this is the last slide before we get into the best practices. I think we've really covered this ground in the slides that we've gone through. Part of your requirements are to be collaborative. Again, to figure out the who's and the how's of what you need to navigate in the emergency. Figure out how do you deal with the fact that at a split moment's notice, you've got to be able to shift changes in the plan of care for the provider, who's reaching out to the doctor, where are those orders being documented, and all of that goes with it. We know that we need that for the safety of the patient, but also it's a compliance issue, and ultimately it's a quality issue. So there's much more that we could go on, but we now need to move to really the core point now that we've sort of talked about the foundation. So Amina, Marlene, turning the mic over to you for these critical sections.
All right, thank you, Al. Good afternoon again, everyone. I just want to start by saying that PACE 11 sites, we are a PACE program, but however, every PACE centers have a LICSR license. We provide a community-based services through a LICSR license, and also we partner with other LICSRs for the aid services. Pretty much our priorities is, to protect vulnerable patients, ensure community continuity of care. And as Al stated earlier, we cannot emphasize that enough. Maintain effective communication prior to, during, and after emergencies. Because by doing this, at minimum, we have a smoother transition during this emergency. So I'm going to share some of the best practices between health plans and home care based providers. First point, always maintain aligned preparedness and response plans. As we stated before a disaster, we have to definitely have the role defined, responsibilities, how we're going to escalate, whom to escalate for, to. As mentioned, establishing relationship with your local partners is crucial to have a smoother, because during the crisis, we're all in crisis mode. So having a plan in advance help determine where to go and how to move forward. So our team at CenterLight, we maintain and review what a list of our partners. We actually update that quarterly. The reason why we do that, we used to have a local Red Cross in one of our centers at White Plains. Through calling, we're finding that the Red Cross have moved and the number have changed. So we learn that you don't want your numbers to be outdated when you're calling your local partner. So that's why it's very important to maintain preparedness. Conduct annual reviews and updates emergency plans, very important. And I think I'll brush on that in terms of conducting disaster drills is very important, because we don't want to have, and different types of disaster drills, not just, okay, emergency snow or flood, but other stuff is very important so we can evaluate our staff response. How prepared are you? And modify our plan as needed to ensure that we can move through a disaster in a more seamless way. Identify high risk patient by maintaining your high priority level, your TAL. You want to make sure your list of participant or patients dependent on electrical is readily available, and your staff is aware on how to not only retrieve those information, but where those information are. I think Emina brushed on that earlier. We make sure monthly we print that list, because if we have power outage, something happened, at least we have something to work on physically, and we're not relying on the internet to help us with our participants. We identify and maintain patient transportation level, as I said before. Next slide, please. Okay. Designated emergency contacts from our partner list or vendor for better coordination in case we need aid services for our high priority participant is important. We need to know the whom to call to make sure we coordinate those services. Conduct proactive outreach before anticipated events to verify food, water availability, medication supplies, backup. CenterLight actually have a call center that receive the calls. We have templates of what to ask, how to gauge what we need to know about these participants. So we distribute that among our staff in advance so they can be familiar and have that ready for them to know what question, because we don't want during the disaster, that's when we're trying to gather information. We don't have that time. We have to act swiftly and promptly. We ensure continuation of essential service, again, by prioritizing critical visits and service. For example, wound care. We know we can, if there's not a family member that was already trained and competent and performing it, and you have it documented that they were competent and trained to do that, then you have to make sure you prioritize those visits for those participants who may need insulin administration and not able to do that. We have that list and we know who they are, because we don't want any disaster. That's when we're trying to figure out who are these people. Developing staffing contingency plans. And I know in those slides, the next few slides, we will talk about some of the challenges, some of the challenges for staffing, especially let's think about the snow emergency we had earlier this year. It's like, staff safety was important, but also participant safety, patient safety and needs needed to be met. So you have to have staff contingency plan. Where are your staff located? And as related to your patient location, who can get there faster with the minimal risk? So we have to have all those plans in place. Ongoing communication, again, I can't say that enough, with all partners, whether it's DOH via HCS, the fire department, local police, and energy department. In some region, we have Con Edison. In some other region, we have other power. So we have to establish that and have those numbers readily available so we can activate those partners when needed. I mentioned that before, conduct training and exercise, emergency drills, test our communication system and responses. At CenterLight, we have many different way of communication, whether it's for all staff, clinical staff has a cell phone. But we also have different methods. We have Emina coordinates that we have walkie-talkie, even though it seems like a thing in the past, but we still need it because in case a disaster occurred while we are at the center, and then we don't have telephone coverage, so we have a way to communicate with our staff and establish or at least follow the plan we have in place. And then post-emergency assessment is very important because we have to evaluate wellness checks. Talking about wellness checks, another reason why we initiate calling our local police in terms of knowing where they are, what number we can access during an emergency to get them directly, is wellness checks. Sometimes we may be doing wellness checks over the phone. But if the participants / patients are not answering, so partnering with the local police, you can use them to make those wellness checks for you. So that's very important. Again, we evaluate at the end, post-emergency, we have to evaluate unmet needs, review outcomes, and implement quality improvement actions when needed. That's what I have so far. So I'm going to give it to Emina.
Thank you, Marlene. Any questions or from the team members that would like? I know we have 66 participants. Anything that we have said so far that you would like to comment or best practice or give us your secret, how you manage, anything to add on? Because we love to share the secrets because we all want to be safe and successful. So I just want to see Al, I don't know who has the control. I did check the chat. I didn't see any questions, but just to put it out there.
No, that's great to just to bring that up and highlight that now. And I just would echo Amina's invitation. Anyone, does anybody want to or either if you have a question or is there a practice that you want to add to the queue that we could share with other partners on the call? Billy, are you able to check the chat?
Yes, and
We're
there's nothing in the chat at this time.
Okay, Peter, were you going to make a comment?
No, I'm just saying we're eyes on the chat, looking for folks to ask questions or offer some ideas that they may have stimulated by the conversation, practices that they can share with others.
What was occurring, I'll tell you what was occurring in my mind, Marlene, as you were going through this was, some of these questions were questions that folks who participated in the in-person training exercises sort of were posed to the table, with sort of a sense as to, what were people doing? What were they planning? This list that you came up with on both of these slides is so instructive. It's so helpful, to just sort of get everybody really thinking in this kind of direction for preparedness. So I'm just thinking about the resource that this is going to provide on an ongoing basis beyond the webinar. So thank you for covering all those. And again, an invitation to everybody that's participating. Put your ideas and suggestions in the queue. We love it. We're going to go to the next portion of this, though. And Amin, I think this is going over to you.
Actually, we do have one question in the chat. Amy Thomas from South Help. I have a question regarding additional authorization. Amy, if you want to unmute yourself.
Thanks, Billy. Hi, my friends from CenterLight. I happen to know that CenterLight works extremely well with their elixrs. Not all plans do. We at Self Help test our emergency preparedness plan regularly in terms of contacting our community partners and things like that. But I will tell you, after being in some wonderful emergency situations, we've gotten calls from hospitals saying, can you take additional patients home, when we are just trying to cover our patients? We've been told not to call 911 in an emergency because they were handling other patients. Of course, we only would call for patients with a significant priority code status, as well as anyone with an electrical dependency. But what most often happens in an emergency, because we're proactive and we're calling the patients beforehand, and we know there's going to be a huge storm or a power outage or in New York City, transportation outage, we have high need patients that we want the aide that's there to stay overnight and continue to work to be with that patient. And this is probably not a good question for CenterLight because they've always been generous with authorizations, but for other plans, they won't authorize paying you for those extra hours. I think that's a problem, Alan. I don't want to blame the plans too much because maybe they don't have the funds to do that, but it's a real problem. No one is going to abandon a patient. But one of the things we evaluate after a drill is how many hours of service we lost, how many hours we provided, and how many hours we're not getting paid for. So it's just an interesting question. If you want to talk about being a partner, you have to look at your most critical patients and maybe authorize some additional services in the event of an emergency. And as I said, I know CenterLight has done that, but I do know plans that won't. So I don't know how we bring that back to the state or make that concern known.
So Amy, that's great. I just wanted to just do an initial response to that, but then Amina or Merlene might want to focus specifically in on what they do as a plan as a best practice in that, or what they would recommend for other plans to do as a best practice. We've at least identified that among the challenges. Amina and Merlene will be going through the challenge slides, and that is absolutely something that is on the list of really unique challenges in this area. I mean, it's unique in home and community-based care because it's not something you're going to experience if you're already in a hospital and you need more service. The staff's there, everything is happening on site. But in the community, you might be one of 40,000 patients that are affected, let's say in the New York City region. And how do you make this all work? And I also think it's something very important for state officials, policymakers, to really understand that this is what plans and providers are facing when there are emergencies, so that there's an understanding of the level of support that's required in order to be able to do it, whether from staff, ranging from staffing to auths and all. But Amina and Merlene, let me have you address that specifically on what you do as a PACE and maybe what you might recommend to plans.
Absolutely. Amy, first of all, pleasure to see you. And I just want to say thank you so much for recognizing the CenterLight being a good partner. We are all aware that, every hour counts, but at the same time, safety comes first. What we do at the CenterLight, and you will see this through a couple of examples that we have, how we prepare for the emergency. We review and we call each and every priority 1, 2, and 3. Every participant that belongs to CenterLight is actually contacted. We also try to first see if the aide either can stay, if the family members are around, because we are very blessed. And as a PACE program, we have all 11 IDT members, which is the social worker, the TRS, the nurse, the doctor. Everybody knows, for example, Al has a sister, or Al has a mom, or Al has someone who can assist in case it cannot get there. If we, for example, are getting a snowstorm, and for example, I'm going to use Westchester in this case. Snow is coming in Westchester. the buses are not running, we will proactively send the authorization and the request and ask the aide to stay there because we know that tomorrow the participant doesn't have anyone, and we know that tomorrow is going to be very hard. Of course, working with Marlene and the team on the clinical side, each and every case is reviewed in advance. That's the advantage that we have. Each and every case, we always plan for the worst. But Amy, I understand that other plans might not have the funds. We always say safety comes first. Participant health and safety is our top priority to make sure they're safe, and also we have a good partners. If, for example, we're very blessed also on the CenterLight side that we do have our facility team, that we have security. In a case we need to transport someone, we actually activate during the snowstorm, during any emergencies, our team with a full wheel drives, and we also centralize ourselves in the different parts where we have the sites, and we actually transport from the nurse to the aide because we know them, we know everything about them, their needs. Do they, need power in the house? Do they need? Are they connected? We know basically pretty much. But that's the communication to what Marlene was saying before. We pre-plan, we plan, we call, and we communicate back. I will tell you also, Amy, we have identified the aide cannot get there, stuck on the bus. We were able to assist the aide ourselves. So we plan for that. Of course, Al is aware, we have to be very careful how we're spending our funds. But if you plan the right way, you can justify, I would never want to say I decline an agency hours just because, for whatever, and God forbid something happens. That's how we do it. It's planning, 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 planning.
And Emina, I think you add one very important element to the PACE program, the IDT, the ability for the interdisciplinary team, the knowledge of the participant, because each participant has a team of IDT, interdisciplinary members that know them, know their needs in advance. Anticipation of some of the needs have already been made during care planning. So that makes it easier. Let's say we have an emergency, we already know who's gonna need and what they're gonna need. But for Amy, I'm not sure, maybe it's partnership with the case manager for that particular participant with the other plans. Perhaps that might help as opposed to just the authorization department. It might be to reach out to the case manager.
Marlene, I agree with you 100%, but Al, this is one of the important issues and a difference between a PACE program and a health plan. And I know this, from experience. The IDT is crucial. They really know what's going on with a case. And for any of the LIXA people on this phone call, they can attest to how difficult it is to directly reach a case manager at a plan sometimes. And they, in many cases, don't know the patient as well as we do. I'm not making this a blame game here. This is about a different type of home care, right? This is a different type of management of home care that the PACE programs actually have over the health plans. They have teams, they have the IDT. That doesn't seem to, yes, they have social workers and case managers in the plans, but they don't have the kind of management that a PACE has. But it is interesting. And again, thanks guys for your words and your suggestions.
Well, Amy, I think so that's really important area to point out in terms of that difference in the, between PACE plans and let's say other plans. But I think what the value of that is that it's really underscoring the importance of a discussion like this, to be working toward those practices that overcome those gaps in the system. So like if you don't have an IDT, well, you still have to be able to coordinate, ultimately that's where the rubber's meeting the road. And so the focus on trying to build those effective practices in place, it's just, I think, affirming the importance of the subject area we're approaching. And this is just the first of what really should be a continued escalating effort to work with plans and providers to really have this honed. So thank you so much, Amy. That, as usual, outstanding comment from your end and from Self Help. So, Amina, I think back to you on we're doing pretty well in our time, but it looks like
Excellent.
now we could have used 5 hours. It's always
Absolutely.
good. So back to you.
Thank you so much, Al. And just, I know everybody has their AC on, but let me take you now to January 25, 26. Just picture this. We're getting the announcements. It's going to be such a bad snowstorm. So, as you know, as we have, I don't want to repeat myself, but we always pre-plan. We watch the weather reports. And when we get notice that significant snow is coming, that is going to impact all of our sites, we start to plan immediately. For example, on January 25th to 2026, we got an updated forecast, which was confirming, of course, everybody knows that we get one day snow, another day it blows and nothing happens, but we are ready. So after reviewing projected snowfalls, transportation limitations, participant vulnerability, and the governor's state of an emergency declaration, our leadership team has made the decision to close all centers on Monday, January 26th. Centers were closed for the staff and the participants. But we always say to our staff, we are never closed. We are working and assisting our participants. Next page. So on January 26th, because the centers were closed, we were not able to bring in the participants safely to our centers. Our remote work protocols were activated for administrative personnel. So our clinical teams implemented the wellness outreach plan, prioritizing high-risk participants to ensure their safety and assess any emergent needs. Overall, the organization response to the January 25th, 26th winter storm demonstrated effective emergency preparedness, early clinical interventions that we have been discussing already before, coordinating leadership decision, making a strong cross-department collaboration. I just want to say that when we start these calls, Al, I don't know if we have mentioned already before, we do have not only the executive team check-ins 2 to 3 times a day, sometimes at 6 a.m. to prepare ourselves, where we are reporting on the most up-to-date weather reports, the transportation, because as we know, things change hour to hour. But at the same time, we have our teams site-specific reporting 2 to 3 times a day as well, any needs and any escalations or any assistance that they might need. So communication is very, very crucial. I know Marlene said it, I need to say it, but I just want to make sure that everyone is aware. Communication and checking ins are extremely important because you can identify the cases that might need assistance and you can act on very, very fast. Our beginning, the preparations for the storm that happened on the 25th and the 26th started on January 22nd, which gave us the adequate time to mitigate risk, ensure that vulnerable participants were supported before and during the closure. The storm served both as a real-time emergency response and a successful demonstration of a disaster readiness planning. Next page. The future improvements include centralizing tracking of snow equipment inventory, all further refinement and participant prioritizing protocols during emergency wellness outreach. The coordinated effort across clinical, facilities, and leadership teams ensured that the participant safety remained a top priority while maintaining regulatory compliance and operational integrity during a significant weather event. Lastly, we established a daily check-in for the remainder of the week. So we all know once the snow stops in New York, actually it's not as safe to navigate those New York City streets. So we also follow for additional few days after the post-storm to make sure that the transportation is available for the wheelchair participants, that every facility that are going to is ready and clear. At the conclusion, while all participants and staff members are accounted for, the team documents the necessary information. I just want to remind everyone on the call that it's extremely important. I don't think so. We have mentioned it already. Every touch, every outreach to our participants before, during and after the storm, it's well documented. So that's something that I want to share with everyone because, for example, if anything happens, we all know who has in our EMR. Everybody can see if I had the pleasure of speaking with Amy or if I had the pleasure of speaking with Marlene already, if they have shared something, so I can do the follow up. So that's extremely important. If it's not documented, it didn't happen. Any questions in regards to our example? Marlene, did I miss anything on the CenterLight side?
Trying to unmute. No, you didn't miss anything. I think we spoke about it, coordination with our partners during those no emergencies, those essential visits. We have arranged with our partner, with our vendor, transportation to actually take our nurses for the high priority patients that needed service for that day, whether it was a medication administration or whether it was wound care. We had our transportation company that we partnered with to make sure those services were not left undone. And I do agree with Amina. Documentation was at the essence of everything we did to make sure everybody is accounted for, and also for quality measures. Also, when we're reviewing what we did right, what could we adjust, what can we do better. It's also depending on documentation. We shared some for our staff who are documenting, we give them some type of draft so they can make sure they're covering all the pinpoint of whatever we need in terms of the wellness, who's in the home, what are the needs. We wanted to make sure all of these things are documented as well.
Thank you so much. So just to be fair, from the snow, I have to take you back to August. So now we are in a very warm, comfortable weather. But on August 6th, CenterLight Healthcare received an important notification from the New York State Department regarding an upcoming severe weather event spanning from August 6th through August 11th. Given the potential risk, we immediately held a team meeting to discuss the necessary preparations. Again, a lot of pre-planning prior to the event. The following careful deliberation, it was decided the CL staff must personally contact all the participants. The detailed participant list was disseminated to multiple team members who took the proactive measures to reach out to all individuals involved. And now I'm going to be sharing the script that was provided to the team. So this is the script that we have created for staff to reach out to the participant and also to document in our system. The National Hurricane Center forecasts heavy rainfall and flooding for our area. We're calling to advise you to have food, water, medication, flashlight available. Please charge your cell phones, your portable oxygen if applicable. Do you live in a basement, lower level? If so, do you have somewhere else to go? If not, the shelter information will be provided. And also, this is our CenterLight number in the case they had any concerns. So the best practices, and what we are also very blessed that our call center, the shared services are not only in New York, and we are providing these services. And we are very blessed that we have the team who can make these phone calls and also document in our electronic medical record. They are also part of our team that is doing the outreach besides the IDT, because sometimes the IDT is making sure that we provide the medication and stuff like that. So we have a good backup. The CL staff took the necessary actions to ensure the safety and well-being of our staff and participants during the impending storm. They distributed the necessary oxygen dialysis equipment and identified resources to provide the transportation to participant home if needed. Additionally, they reviewed the list to determine which home visits were critical in the case where there was any access issues. To the point what my colleague Marlene has mentioned, when necessary, we are transporting our nurses to complete these visits, but also we plan ahead if it's possible to do the visits prior. But if it's needed to be done during the the storm, we are also providing that service. We also ensured that all facilities were monitored, flood prevention precautions were in place, and lastly, we established a daily check-in the remainder of the week. So you can see in each and every disaster, we have the pre-planning, we have during the storm, and then after the follow-up for the 2 to 3, sometimes even 5 days. The most important part, and when it's for us to take a deep breath after the storm, that everyone is safe and accounted for, and also documented in our EMR that everyone was accounted for, that we got in touch with everyone, each and every participant is safe. Any questions, any remarks? Okay, so the challenges. Al, do you want me to take this?
Sure. Why don't you? Yep, absolutely go for it.
Thank you, sir. So everybody knows that the worker shortage, staffing adequacy, including the surge capacity, it was mentioned here by Amy also, when the transportation stops and the aid cannot get there somewhere, and we are in dire need of finding the staff to cover the cases. So I'm going to say again, the PACE program is pretty special. Our IDT members, because we have so many locations, we are all reporting to the closest site. We all share our locations where we live. We all can go and cover each other at the site that is closest to home. So sometimes the worker shortage, it can happen, but with the PACE program, when all the IDT members that we have, we're pretty successful, but I know that can be a pretty burden on some other agencies. Navigation across wide-ranging community risk areas impacted by the emergency. The challenges that we also have, many years ago during Sandy, we did lose few actually sites due to Sandy. So our facility team members are pre-planning for all the emergencies the day before, sometimes 2 days before, and very proud to say that they also, in 20 years that I have been with CenterLight, they always reported, and our sites were always ready to accept the participants, even in the middle of a snowstorm. The medical record communication, coordination, including navigation of the electronic health record system between partners. That's an issue because we wish that we could all use the same system and communicate any issues, any triggers. I know other agencies, especially communicating to the outside providers, could be an issue, reaching them during an emergency. The MD coordination, that's a unique challenge. The coordination with HCBC partners and EP partners across the community is necessary. Mutual aid agreements, training and ongoing mutual planning. I just want to remind everyone of the importance, and as we're all sharing our success, our tricks, that trainings, and once a month, updating that list, your emergency preparedness plan, because the team members come and go. Some people leave, some people join. You also want to make sure that you orient and part of the new hire for the emergencies, that you orient them. We have our security manager, Mr. Nolasco, who all new hires oriented on the emergency preparedness, on how to act in case there's a shooter, any emergencies that you can think of. So that's something that it's really important, especially for the new team members that are coming on. The health plan inclusions and collisions in both regional and statewide EP planning. And our funding, the health plans and providers negotiate rates for services and other terms of their contracts, essential to recognize EP costs and reimbursement needs in the premiums funded to health plans and rate payments to providers. And currently, EP is a heavily under reimbursed cost in the CBC system.
As we go to the next slide, which is I think maybe our last slide before the appendix. I just want to, one of the things to really underscore is that it's not that there's some built-in component of the plan's premium or to the provider's rate or their capability in negotiation to cover the costs for this extensive planning and service. In fact, it's something that really falls under the A&G, which is now under this most recent state budget was capped at least for fee-for-service personal care providers. So really, these challenges that you see, we're sort of bringing them to the surface. We're putting them on the radar to say, yes, these are challenges that we have. Hopefully, as you try to synchronize the best practices that Amina, and Merlene, talk to, some of those will help navigate these bridges. But really, this is something for us all to be working on together, to recognize together these are major challenges as health plans and providers try to navigate this system, and where we really need to work together to bring to the attention of our officials for areas for support. I guess that was the page. I guess that was the last slide before the appendix. So we can stay on that, or I can let the share screen go down and we can take questions and further comments. Amina and Merlene, back to you to see if there's other elements, other angles that you want to focus on this page. Otherwise, we're doing really well on our timetable.
We're very, very efficient. You can tell how we do it CenterLight side. So I just want to say, first of all, thank you for this opportunity. And I think this is excellent way of us communicating and sharing the very important information. I think these are very beneficial to all of us. We all are learning and adjusting as we go. And again, I did check the chat. I didn't see any questions. The only question that I could see was actually from Amy for the additional, I think that was already addressed. And I'll leave it up to Merlene and Al to close it out. Thank you.
Yes, so let me invite any comments, again, questions, any discussion points. Peter has some important information to share, and while he's sharing that, Billy, I wonder if you would be able to bring these up. So Peter is going to bring up or I didn't think you put in the chat, Peter, but can you just describe what you're making available to people in the chat, which is a great resource?
Happy to do so. And first, I want to thank our panelists for a tremendous presentation on such an important topic. And we have a lot of ongoing work to do in collaboration to really bring full realization to this level of coordination between plans and providers. And so thank you all for that. Part of HCA's grant-funded activities this past cycle have included a whole series that Al mentioned earlier on emerging infectious disease. And we have a 5-webinar series that we held with partners from iPro that we have made available on our website to anyone who wants to view it. And that's the link that I put in the chat. And these 5 webinars really take us through a full range of efforts to respond to and manage infectious disease within home and community-based service environments, and doing so from multiple perspectives: interagency collaboration, patient education, direct service services. We also will be posting other assets from this important initiative that was funded through administered by New York City Department of Health and through the grants from the administration. So I'm sorry, I lost my slide there with my cheat sheet on our acknowledgements, but nonetheless, you'll see all of that on our website. So please do visit that and engage with us around our emergency preparedness activities and the breadth of them that we are really looking forward to continuing to support.
We have thank you so much, Peter, and really I think it's is a very unique and very comprehensive series. Again, courtesy of the New York City Department of Health and their sources for federal funding that enable us to put this sequence together. Because it not only focuses on some of the critical and new coming threats from infectious disease, but also the complications that result from infectious disease as they occur. Things like pressure injuries, UTIs, sepsis. All of those kinds of things that are extremely threatening to patients, even life-threatening, and of course very costly in the system to manage. So there's a lot of really great information on there. What Peter put in. One of the things that we'll try to also send you, I didn't think to have them in the queue in advance, but there were 3 sessions that over the course of the last maybe 15 months that we've also held that would be really valuable for you to have. One is a link to a session that we did on February 19th, which is really focused on the individualization of emergency planning for every care plan. That is also a federal requirement, but it's not easily done, and we have some great best practices on that. The other, as I mentioned earlier, was on mutual aid agreements and what are best practices for that. And then another presentation which is on resources, existence of very useful training resources which everybody needs to sort of take internally. So we'll be making those available to you unless Billy beat me to it and put them in the chat. Otherwise, we'll send them along.
Yeah, I will be sending the slides, a recording to today's session, and those 3 links that Al just talked about. I should be sending those out on Tuesday. I'm taking a couple of days off, but Tuesday morning.
When you exit, before you do, just please be alert that you'll get a pop-up for our evaluation, which is a very simple SurveyMonkey survey, and really appreciate you providing your feedback and response to today's program. It's important to us as we plan and move forward. So
Thank you, Peter. Billy, Peter, Fidel, Amina, Hector, Merlene, Nancy, everybody in the mix. Thank you so very much for your presentation, and to all of you for your participation. Fidel, always thank you in the city of New York.
Thank you for the opportunity, everyone.
Thank you for having us.
Thank you.
Thank you for
Thank you,
presenting.
Al.
Thanks for attending.
Yes.
Thank you.